In this lecture, we'll talk about the viral diseases that can affect the cardiovascular and lymphatic systems. So there are a number of viral systemic infections that we'll talk about, including mono, cytomegalovirus, yellow fever, and the hemorrhagic fevers, which is going to be a large family of diseases that we'll touch on. So what most people think of mono is officially known as infectious mononucleosis. If you recall, we met the different varieties of human herpes viruses. So number 4 is also known as the Epstein-Barr virus, or EBV. And this is transmitted through saliva. So very oftentimes they call this the kissing disease. And most people get exposed when they're young. And so the virulence factor here is very unique in the fact that this virus infects B cells. So recall, that's part of your adaptive immune system. And what happens when a B cell gets infected is that it leads to what they sometimes refer to as a civil war between the B and the T cells. Because recall that T cells, cytotoxic T cells in particular, are designed to kill virally infected cells, which in this case happens to be a sibling cell within the immune system. So it creates quite a problem for the body. So signs and symptoms are fairly mild for most people, but can lead to extreme fatigue, lack of concentration, enlarged lymph nodes that can last for months. And so again, it really depends on the condition of the immune system, what kind of symptoms you're going to see. And this largely is associated with age. So for example, if you have absolutely no immune response, so completely immunosuppressed, one of the signs or one of the diseases that can develop is called oral hairy leukoplakia, where you have basically precancerous changes in the tongue. In parts of the world where you have malnutrition and sometimes a co-infection with malaria, you might see Burkitt's lymphoma, which again we talked about the risk of viruses causing cancer. That's one of them. If you have a normal, healthy immune system, so in children, not very, very young children, but children whose immune system has begun developing, they're usually asymptomatic, and most people are exposed during that time of their life, and so they don't even realize that they've been exposed. But if you are an adult with a vigorous immune response, you're actually going to have this infection, and the symptoms are going to be much more severe in an older individual. So diagnostics requires looking at the blood, and you would see that the cells, the reason why it's called mononucleosis is the cells end up with these very large inclusions that can be seen under the microscope. And so again, about 95% of people in the US would actually test positive for this virus over the age of 30. It's a very common disease that most people have been exposed to. And because it's a double-stranded DNA herpes virus, it will embed itself permanently in the DNA. So it can become a lifelong infection in some individuals. Treatment, again, viral infections very rarely have any antivirals that are effective, and in this case really just focusing on any symptoms. Most cases, again, are asymptomatic and usually resolve without treatment. And the younger the patient is, the more mild the immune response. And so again, that T and B cells, they won't have quite the vigorous civil war if your immune system isn't fully developed yet. Then we have one called CMV, or cytomegalovirus, and this is actually human herpes 5. So this is another one of those very common infections. In fact, it's one of the most common viral infections, and most people never hear about it because most people are asymptomatic. But this is, again, a herpes virus that can permanently embed itself in the DNA of the host. And so the highest susceptibility here are unborn fetus, the newborns, and immunosuppressed or immunodeficient patients. And so this is transmitted through bodily secretion. So sometimes it's considered an STI or sexually transmitted disease. This is the C in torch, which means it can cross from mother to the developing fetus. And in some cases, it has been documented to be passed through solid organ transplants. So this one again, they can do microscopic analysis and look for these unusual inclusions in the nucleus, which is where they get the name cytomegalovirus, very large cell essentially. And again, mostly asymptomatic. The complications we tend to see are in very young or immunosuppressed individuals. So again, in a developing fetus or a neonate, it can lead to neurological problems, so mental defects or even fatality. In HIV/AIDS patients, it can cause a form of pneumonia. Again, it's very difficult to prevent a virus that's that widespread and easily transmitted through body fluids. So again, safe sex would be one way to prevent transmission through bodily fluids. We don't currently have a vaccine available yet, but there is only one treatment available, and typically this is for very young patients. If the virus is starting to affect the eye, then fomaviricin can at least reduce the spread and hopefully prevent it from permanent damage to the retina, which could cause blindness. So now we'll talk about some of the zoonotic diseases, which includes the flavivirus, which causes yellow fever. And this is coming from a monkey reservoir by way of Aedes mosquito bites. And so keep in mind, Aedes mosquitoes are daytime feeders, which means humans are a very likely host. And this virus has preferential affinity for the liver, and that's where it's going to replicate, and some of the symptoms can affect the production and secretion of bile, which is why it got called yellow jack, because some of the symptoms we're going to see includes jaundice. So currently cases are primarily in South America and Africa, but we did have cases in the U.S. Back in the 1800s when slave ships had brought the disease over. But we don't have any resident monkeys in North America, so it can't persist here. But in places where it does exist, it's virtually impossible to eradicate because they're a wild monkey reservoir. So here are some of the endemic areas for this virus. And again, so if you're a traveler to these parts of the world, you're going to be required to be vaccinated and have what they call the yellow card that goes into with your passport, because they don't want people coming from non-endemic areas getting infected and then taking it back to their own countries. So even if there are no native monkey reservoirs, humans are essentially the equivalent of a monkey reservoir. So if you have the Aedes vector, it could potentially be passed in that way. So the first signs and symptoms occur in different stages. So the first stage, very vague symptoms of fever, headache, myalgia or muscle aches. The second stage can go asymptomatic for some long period of time in remission. And then only some individuals, about 15%, will progress to this third stage, which is really the characteristic stage where you have jaundice form. And it'll also have neurological problems. So you'll have seizures, potentially delirium, coma, and sometimes hemorrhaging. And so this falls under the family of hemorrhagic fevers. Prevention, again, we do have an effective vaccine, and it's required for those that live in endemic areas, and it's also required for travelers going to those endemic areas. So visiting those areas, obviously avoiding mosquitoes, using bed nets in endemic areas, and using DEET or other insect repellents. So diagnosis, there is an ELISA and DNA or PCR test that can confirm based on symptoms or known exposures. But treatment, there are no antivirals. We just have to give supportive care depending on the symptoms. And then there's a disease called dengue, and dengue really comes in two different forms, what we call dengue fever and dengue hemorrhagic fever, which is a much more severe form. And there are 4 different viruses. The dengue viruses, they just numbered them 1 through 4, and each one can cause disease that's independent of the others, if you will. And so again, Aedes mosquitoes, monkey reservoirs, but again, if you get into an area where a lot of the humans are infected and you have the Aedes vector, you can actually have an outbreak. And so typical signs and symptoms, again, there are 2 different stages of the dengue fever version. The first of which is very, again, vague: fever, headache, and muscle pain. The second phase can be a rash and a return of fever, but only if you get reinfected with the same strain of virus will you have what's called dengue hemorrhagic fever. So again, it's the more severe and it's sort of the secondary version of the infection. So you can get dengue fever 4 different times if you get exposed to each of the 4 different viruses. But the first time you are re-exposed to any one of them, you'd probably get the dengue hemorrhagic fever, which is much more severe and has the characteristic bleeding and is potentially fatal. So it's much like how your body, if you are allergic, the first time you're exposed to something, your body doesn't respond, but you do make antibodies. So you essentially get sensitized to that antigen, and then the next time your body is exposed, it basically overreacts to that antigen by way of memory cells. And so in this case, the dengue hemorrhagic fever then leads to the more severe complications of the disease. So prevention, again, we have a couple of vaccines that have been in development, one of which is considered a tetravalent, meaning it's going to protect against all 4 different strains of the dengue virus. And currently, the vaccine that's in use is limited to people who live in those endemic areas. And only those who have had a previous known infection. It turns out those vaccines are actually cause severe disease in people who have never been exposed to the viruses before. So it is a complicated vaccine. But fortunately, dengue fever, the initial version of the disease, is usually fairly mild. It's really the hemorrhagic form that we worry about. It's much more severe and possibly fatal. And so diagnosis really depends on characteristic signs and symptoms, or knowing that you've been traveling to an area that is endemic. And again, there are no known antivirals, so really no specific treatment, just supportive therapy. Avoiding mosquitoes is really the key. Then we have a hemorrhagic fever or a family of hemorrhagic fevers that is endemic to Africa. This includes Ebola. So most people just think of the name Ebola. And these are under the category of filoviruses. If you recall, their capsids have that very unique sort of shepherd's hook shape. And the Ebola virus comes in 3 known strains: Zaire, Sudan, and Reston, which, yes, that represents Reston, Virginia. That strain actually developed in the lab in one of our biohazard labs in Virginia. And then there's also a version of the disease that's called Marburg virus, which was from Germany. So again, they're called African viral hemorrhagic fevers, but that's because that's where they were first described. And so the virulence factor here is the fact that when a macrophage gets infected by this virus, it triggers clotting cascade systemically. And so recall your disseminated intravascular coagulation. And so when you have all of your clotting factors getting triggered at the same time, you basically deplete the circulating amount which means any clotting that needs to happen in the body can't because there's not enough clotting factors available. And that's what leads to hemorrhaging. So it sounds a little bit backwards that you're clotting so much that you're going to bleed to death. But most people don't realize that microclots are forming at all times. Every time you move your body, you're probably straining and breaking little capillaries here and there. And so your clotting cascade is constantly being used to keep just minor clots from or breakages from bleeding out. And so when you've used up all those clotting factors, the liver can't keep up, and hemorrhaging is the result. So here's a general distribution of some of the historic cases. We had the most recent big outbreak of Ebola was in 2014. You may recall we had some travel cases that even came to the United States by way of doctors who had been over there helping to deal with that outbreak. And early diagnosis is usually fairly difficult because it's very vague and flu-like, but later stages are those that are characteristic, which includes hemorrhaging. And so if you know you're in an endemic area, you know you've had contact, that's the best way to be able to diagnose it earlier when they have outbreaks, unfortunately. But they can confirm the presence of the virus in the blood if they go and look for it. Having an active patient contact history is really key to stemming the tide when there is an outbreak. So because this virus is spread through bodily fluids, avoiding contact is really the key. And this is where the early outbreaks are really important, because when a person becomes infected, recall that some of the symptoms include seizures. And so if they're hemorrhaging and bleeding out of their eyes and every orifice, and then they're seizing, they're basically spreading the body fluids quite readily. The other problem is when someone dies with the Ebola, the mourning rituals in this part of the world require the loved ones, friends, and family to touch the body before it gets buried, and that just further spreads the virus through the community. There are also known animal reservoirs, and so, for example, that 2014 outbreak, they actually tracked patient 0 to a man who had eaten some wild antelope. And so we know that there are some animal reservoirs. They suspect that it also includes things like fruit bats that live in caves, monkeys, and even rodents. So when we say bushmeat, we mean those wild animals that are brought in for food. So preventing the spread can be just as simple as isolating those known cases. And so 21 days typically covers the infectious period. So if a person can survive the infection, then they'll no longer be infectious. So that 2014 outbreak actually made a huge push for vaccine development. And so there is a vaccine that came out of that period against the Zaire strain, but they're still working on one that's effective against the Sudan strain, which is the second most likely or common strain out there. So another round of treatments came out from that research as well, which included antibody treatments. And so there are some effective antibody treatments, as well as providing fluids, because that hemorrhaging, they're going to lose a lot of blood, but also giving anticoagulants before that clotting cascade begins can also prevent the hemorrhaging. So it sounds a little bit odd. I don't want you to bleed to death, so I'm going to give you an anticoagulant ahead of time. And so it just can bypass that DIC problem. And then we'll just touch on some of the other viral hemorrhagic fevers that are not quite as commonly known, which include the chikungunya fever, which is really endemic to Africa, Asia, and Europe. This one is a mosquito-borne viral hemorrhagic fever that actually was diagnosed in the Caribbean as locally transmitted. So even though this is a disease of Africa, Asia, and Europe, it is now actually considered a notifiable disease in the U.S. because of these recent cases. Unfortunately, there's no vaccines or antivirals available for that infection. Unfortunately, it's typically mild, but it can be a severe disease in newborns, in the elderly, and people with predisposing conditions like diabetes or cardiovascular disease. Then there's one called Nipah fever, and this one actually is mostly in the Malaysia, India, Bangladesh, Philippines part of the world. And this one is sometimes called the mile-long cough because it can get into the respiratory system of pigs. And as noisy as they are when they're healthy, when they have this particular infection, their cough is essentially really a piercing sound that can be heard from a long ways away. It's actually naturally found in fruit bats and can be transmitted directly from human to human as well once they become infected in their respiratory tract. But typically how it's transmitted is through ingestion of date palms, either the fruit or the sap. And the problem is fruit bats basically get into these orchards where they're harvesting date palms, and they go in and they're licking on the little collection jars, and then the virus gets into the actual product, and it doesn't get pasteurized, and so that's typically how people get it. How pigs get it is very oftentimes in this part of the world, pigs are not very tolerant of full sun, and so very oftentimes the orchard is where they keep their livestock as well, because it's a tree. And so what happens is any of the date palm fruits that the fruit bats eat and maybe don't consume the whole thing, their saliva produces the virus. It gets on the fruit falls to the ground, and the pigs are down there and they will eat the fruit, and that's how the pigs get infected. In the Philippines, apparently horse meat is one of the ways that it is transmitted to humans, because horses will ingest the fallen fruit, much like the pigs in Bangladesh. And so when they get infected, if you don't cook the horse meat adequately, it can be transmitted that way. So it's a really interesting disease, but it can cause very severe disease and has up to a 75% mortality rate. So, and if you survive, typically you're going to have very long-term neurological problems, everything from just personality changes to severe fatigue, seizures, things like that. And so because it is a very severe disease, in fact, and has huge economic impacts. So in places like, again, Bangladesh, where the pig livestock industry takes a huge economic hit because they have to cull the herd when you get when they get infected. So I forget, a few years ago they had to cull millions of pigs because it was widespread outbreak of this disease. So, so there is a messenger RNA vaccine trial that's in progress. So they're using the technology that was really, we worked out all the kinks finally during the COVID pandemic. And so there's a lot of good research that shows most of the vaccines of the future are going to be messenger RNA vaccines, because that technology is very effective, it's very fast, it's cheap compared to other vaccine methods of producing vaccines. So hopefully they will have an effective vaccine for that in the near future. In South America, we have another one called Lassa fever. It could also be found in Western Africa, and this one's kind of unique because it has a rat host, and basically its droppings, when they become dried, then get aerosolized and people breathe it in. So this one, there's no vaccine, but there is some early treatment with ribavirin that seems to be effective, but otherwise we don't know much more about that disease. In Africa and Saudi Arabia, there's Rift Valley fever, and this one is transmitted again primarily through mosquitoes, but also by way of either direct contact or aerosols of livestock or unpasteurized raw milk. And so again, this is essentially a zoonotic disease. So in domesticated animals, like sheep, goats, camels, those that are typically milked, can cause significant economic losses, mostly because of the loss of young individuals. So there's about 100% fatality rate in lambs when it gets into those herds, and about 70% in cattle. So even though in humans it doesn't cause very significant infection, it is primarily a livestock, domesticated livestock disease. And then there's HIV, so human immunodeficiency virus. So this is one of our positive single-stranded or sense-strand retroviruses. So recall, this is a virus that can come in as an RNA virus, but can embed itself permanently into the host DNA. And so a couple of the sort of structures here that we're going to talk about, what we call GP12041, is the glycoprotein on the surface of the virus that it uses to dock into our host cells. Then recall, it is a retrovirus, and that means it contains an enzyme called reverse transcriptase. Typically, transcription happens from DNA to RNA, but these viruses can go back, which is why they're called retroviruses. And then they have an enzyme called integrase, and this is basically how they integrate themselves into the host DNA. And then they have a protease enzyme that allows them to escape the host once they have replicated. So the two major strains, HIV-1, which is the one that was discovered in the US and Europe, and then what we call HIV-2, which is the strain that's predominant in West Africa. It turns out the West African strain is actually the older of the two strains, but it was described second. So recall the life cycle of viruses. They have to bind to a host cell, they have to insert themselves into the host cell, they have to get copied while they're in the host cell, and then they will assemble and be released. And so in this case, this is going to be a virus that preferentially infects helper T cells, and it uses the CD4 receptors, which, by the way, the alternate name for a helper T cell is a CD4 receptor, and it's because of this receptor. And so that GP12041 has the affinity for the CD4 receptor. Once it inserts itself into the host cell, it then copies itself by way of reverse transcriptase, integrates into the host chromosome, then assembles and releases by way of protease enzymes. So remember that HIV and AIDS are two different things. HIV is the virus, while AIDS is the result of a long-term HIV infection. So let's look through the progression of disease. So the green line here represents the number of CD4 or helper T cells at the beginning of infection. The red line represents the HIV content. So you can see how those two lines basically reverse, because in the initial couple of weeks of infection, the HIV is finding its way into host cells and killing them. And so the number of helper T cells really declines by about 50% in the first couple of weeks. But the purple line, or the lavender line here, represents the antibodies against HIV. And again, we know that the initial infection, the primary humoral response, is fairly slow. And the cells that are typically giving permission to make antibodies are the target cell here. So antibody production is usually fairly slow, even slower than you would see in other infections, because the helper T cell count is going to drop so dramatically, so quickly. And so antibody titers will go up. The viral load, you can see it looks like it disappears, but it's really because you're talking about how much is actually available in the blood to be detected. But as the HIV is finding itself into finding its host cells, it's basically hiding away. So it looks like the virus disappears, but it's really just undetectable because it's inside and embedded in those host cell DNA. So you may then enter a clinical latent period that could last for years. And you can see slowly as that virus continues to replicate, it keeps killing off those helper T cells. And it's really not until helper T cells or CD4 counts drop below 200 cells per millimeter of blood that you end up in the condition where we would refer to it as AIDS, because that is when your opportunistic infections or secondary infections can take over, because now you've taken out so much of the helper T cell count that they can no longer manage the adaptive immune response, and people become highly susceptible to secondary infections, right? So HIV doesn't kill the AIDS patient. The lack of an immune system, the immunosuppression, is what kills them when a secondary infection comes in and takes them out. So again, diagnosis of HIV requires detection of antibodies against the HIV virus. But just testing positive for HIV does not indicate AIDS. You have to have the combination of criteria. So you have to be HIV positive and have the presence of one or more defining disease, which is what we refer to those opportunistic or secondary diseases, or HIV positive status plus a CD4 count below 200 would be then how we diagnose them as an AIDS patient. So remember, they are not synonymous. HIV is the virus, AIDS is the resulting syndrome, which of course represents acquired immunodeficiency syndrome, not to be confused with autoimmune, which is things like rheumatoid arthritis, where your immune system is targeting your own natural healthy tissues. In some very small cases, there are people who have been HIV positive for decades and never seem to progress to AIDS because they don't actually kill off those helper T cells. And we call these long-term non-progressors. And they believe that it's partly due to whichever strain of actual HIV that they get exposed to. And remember, HIV is one of these viruses that mutates readily. And so the virus that you're infected with may look very different by the time you pass it on to someone else. But it may be that the version of the virus they got infected with was somehow defective, and it didn't have the right, perhaps those GP12041 surface markers weren't the right shape to actually infect helper T cells. In some cases, the non-progressor has helper T cells with receptors that don't fit the HIV virus very well. Those CD4 receptors might not be the right shape to effectively bind and invite in the virus. And in some cases, even if the virus gets into the helper T cell, they have such a well-developed immune system that they can counteract the loss associated with it. So there's a lot of research into these non-progressors to see if there's something that we can use as a therapy or a prevention by way of how their immune system functions. So what we call the defining diseases. These are those secondary or opportunistic infections that are typically fairly rare in healthy individuals. So unless you have immunosuppression associated with the HIV AIDS status, these are probably not infections you would see. And so, for example, pneumonia, I've got a couple of them asterisks here that are really the primary ones. So recall that pneumocystis pneumonia is very rare, right? Fungal pneumonia is something that most of us are exposed to. This fungus. It's a spore that gets into the air and most of us breathe it in, but your immune system is typically very good at keeping it in check. In HIV AIDS patients, that's not the case. In fact, that is actually the disease that allowed the initial diagnosis of and discovery of HIV, because we had a large proportion of homosexual men in a small community all getting this very rare fungal pneumonia, and that doctor went in and tried to find what did they all have in common, and they discovered this virus. Tuberculosis is also asterisked here. A lot of people are asymptomatic carriers of the bacteria tuberculosis, but if you have a healthy immune system, it keeps it in check. And so some of these other infections we've talked about before, some we haven't talked about yet, but these are, this is part of the list. There are other diseases, but these are what we call the defining diseases. So if you have one of these plus HIV positive status, then it would be then crossed over to the diagnosis of AIDS. So most people are familiar with the fact that transmission of HIV is primarily through sexual contact, but it can also be through blood. And so IV drug use is also a very common transmission mode. It can cross over the placenta, so this HIV is categorized under the O in TORCH for other. It can also be passed through breastfeeding. And so obviously behaviors can increase the risk. So anal intercourse, that part of the body is not physically designed for the kind of friction that happens with sexual contact, which is why it's much more common in that type of behavior. The presence of HIV is very closely tied to the presence of other sexually transmitted infections. In fact, HIV cannot cross over the mucous membrane if it's intact. So the presence, so sexual promiscuity increases your risk of any STD, and any other STD that produces a lesion increases the chance that HIV will be transmitted as well. So that's really the connection between sexual promiscuity and HIV. It's the presence of other STDs that increases the risk of HIV transmission. And again, IV drug use, so people who inject drugs are very likely to transmit it that way. And sexual intercourse with anybody who is in those other high-risk categories can increase the risk of transmission. So the way we treat and prevent HIV is through antiretroviral therapy. So this is really what we call the cocktail, right? So there's a cocktail of antiviral drugs. Typically, it's a combination of 2 reverse transcriptase inhibitors to keep it from creating that DNA strand and inserting itself permanently in the host cell, and a protease inhibitor, which inhibits the ability of an infected cell for releasing new virions. So treatment with these antiretroviral therapies can improve the quality of life. It cannot cure the disease, but we have seen it increase the survival rates by more than 10 years in most cases. Children typically require more aggressive treatments because their immune system is not yet as active as adults. So vaccine development is very problematic, primarily because, again, these viruses can replicate and mutate when they replicate. And so there's some evidence that shows the strain that you get infected with on the front end of the infection, by the time you've gone through the clinical latency phase, asymptomatic phase, and decades later, you may have up to 100 different varieties of the virus in your body. And so, of course, we know vaccines can only target stable shapes, right? And so if it mutates, that is really the primary reason why it's been problematic to develop an effective vaccine. Opportunistic diseases can then just be treated on an individual basis. So if an HIV/AIDS patient is diagnosed with tuberculosis, then they would treat the tuberculosis. So again, there's really no cure for HIV/AIDS. All we can do is limit the spread, and we know that that is based on behavior. So abstinence, safe sex, use of clean needles for IV drugs, blood products. So we know that historically, if you were a hemophiliac and had to get blood transfusions, your risk of HIV was very high. But now we have proper screening protocols for blood donation and blood transfusions. If you're handling blood, obviously using the proper protective equipment. We know that many of the new cases of HIV are spread from mother to baby, either across the placenta or through breastfeeding. And so we know that in a lot of parts of the world, breastfeeding is the only option for feeding that baby. And so even if they know they're HIV positive, the choice is difficult to choose not to breastfeed. There's no formula, there's no other options. So we know if that pregnant woman or breastfeeding woman is given antivirals, that it can almost remove the risk of transmitting it to that baby. Now, getting those medications to the people who need them is still somewhat of a challenge. So we do have a number of medications are out there on the market now for what we call PrEP, pre-exposure prophylaxis. So if you have a known partner that's HIV positive, taking these consistently can reduce the risk of transmission. Unfortunately, anytime you take any antibiotic or antiviral prophylactically, you run the risk of driving resistance. So again, this virus mutates readily. If it is consistently exposed to the most effective medications we have, which by the way, which is what this prophylaxis is. You're basically just taking the antivirals that we use to treat the infection. And if they're on board immediately, during the exposure, then the risk of actually getting infected is reduced. If you have an accidental needle stick, they might give you post-exposure prophylaxis. But so this is with a known exposure, and they're really most effective only if they're taken within the first 72 hours of exposure. We also know that circumcision, in places in the world where it's not a cultural norm to get circumcised, there is a higher rate of HIV. And so that's been fairly controversial over the years. Is circumcision just simply aesthetic, or does it actually protect against transmission of disease? And it turns out it does, in fact, limit the spread of certain infectious diseases. It doesn't so much protect the individual who's circumcised, but it protects their partners. And so we know that can reduce the spread of the virus.